Welcome to the WavelinQ EndoAVF webinar. I'm Dr. Todd Berland. I'm a vascular surgeon out of NYU, practicing in New York City. And with me, one of my colleagues, Dr. George Mueller. Dr. Mueller, how are you?
I'm doing great, Todd. It's so exciting to be here today to discuss wavelength, and I'm honored because I'm following the pathway that you blazed in doing the original research to make this procedure a reality.
Now, George, your background is that of a vascular surgeon. Is your practice mainly that of a vascular access type of practice?
Well, you know, Todd, I was around when actually Moses had to have his AV fistula created. So I've been in practice now for 38 years, and I've been doing dialysis access for over 40. I was trained as a general surgeon at the University of Michigan, and have practiced general and vascular surgery in my geographic locale for the last 38 years. Now, my practice now still is general and vascular surgery. The vast majority of it is vascular surgery, and the vast majority of that is dialysis access.
Excellent. You've got so much experience. I'm looking forward to our banter back and forth here during this session. You've got decades of experience in access creation. Before we get into the nitty-gritty here, what brought you to WavelinQ? Why did you want to incorporate EndoAVF into your practice?
What I had hoped in embracing WavelinQ is that a minimally invasive approach would become attractive to the patients and our nephrology community. And so that's why I embraced it and got involved with it.
So the WavelinQ EndoAVF system, 2 rapid exchange catheters, 4 French compatible sheaths. I prefer a 5-4 Terumo slender sheath to allow for the device and the 014 wire to be alongside the device. Several magnets with a rotational indicator, both on the end and near the money part of the device, so to speak. So the money part of the device, where the business happens, between the electrode and the backstop. The backstop is inside the patient's artery. The electrode is inside the vein. Once properly aligned, you activate the device and you cut from the electrode side, from the venous side, into the arterial side to create your AV fistula. There's no magic to this. It's an RF system creating heat energy to burn a hole from the vein into the arterial side, making a fistula. And a lot of people will wonder, well, how come you don't get frank extravasation? How is there not some giant pseudoaneurysm? There really is no magic to this. You're burning a hole and the blood is following the path of least resistance, since the WavelinQ device is using RF energy to cut from the venous side to the arterial side to create an endovascular AV fistula. So this is showing the RF generator with the 2 catheters, and what we're about to see is a cartoon animation. You've got arterial and venous access into the brachial artery and brachial vein, with the devices manipulated within the artery and vein themselves. We're always creating a fistula ulnar or radial artery, and in this particular case, you could see the connection between the artery and the vein. The magnets are aligned. Once we confirm they're aligned, we remove the wires. The 014 wires come back. We're left with the device in the artery and the vein. We activate the device. We remove the devices and we confirm a patent AV fistula. Now, access hinges on flow in those superficial veins. To improve that flow superficially, we often place a coil in that brachial vein to coax more flow superficially to facilitate dialysis. This is a fluoroscopic image. We're used to using fluoroscopy for most of our endovascular procedures. As you can see on screen left, we've got the image of the latest WavelinQ device with the arterial and venous devices in position, ready to fire. What we see is the arterial device with the ceramic backstop towards the top of the screen and the electrode in the vein towards the inferior or bottom portion of the picture. You can see rotational indicators just to the left, which shows you that your alignment is okay and you are ready for activation in this situation. And on screen right, you see a completed AV fistula. Now, there's a learning curve to just looking at these fistulas because we're not used to seeing arm anatomy under these circumstances. We're certainly not used to seeing arterial and venous anatomy superimposed on top of each other. So what you're seeing on that screen right is the arteries, the veins, the fistula in the center of the screen, a nice big perforator carrying that flow superficially into a cephalic and basilic vein on the top and bottom of the screen, exiting screen right. You can also subtly see that little coil in the brachial vein just central to the fistula itself. Now this is showing where the green boxes demonstrate where the fistula is created. But what we're hoping for is a nice fistula creation in that site and then flow via a perforating vein carrying that blood, that higher flow blood now into a cephalic and basilic vein. Now we often can't predict which vein is going to dilate up, and more often it is a split outflow situation where you've got some flow diverted into cephalic vein and other flow diverted into the basilic vein or median cubital vein. So the benefit of this, in my opinion, is that you've got flow going into two veins at a lower flow rate and the split cannulation that facilitates dialysis. Now, WavelinQ is not just a device, it's not just a procedure, it really is an entire program. And it really behooves us as specialists, as vascular surgeons, as interventional radiologists, as interventional nephrologists, to lean on them for their training and support. They do offer comprehensive training to your staff, from the techs down to your assistants procedurally. They offer ongoing support with their specialist teams, intraoperative, perioperatively. They have several tools for their EndoAVF program involving lots of different options for you as the user to learn and gain experience with the procedure. And it really is a patient-focused journey. The patient is at the center of this journey. We often will have BD follow these patients to their first cannulation site to make sure that the nurses at the dialysis centers are getting the needles in the right places. Again, this is a whole new program, procedure, device, everything, and really goes from the patient, from the onset right through to cannulation, and WavelinQ and the team at BD is there the whole way.
So Todd, my experience was slightly different than yours because, as I previously said, you charted the way down in Paraguay, but I followed this up, as what we now recall, or what we're calling a real world experience. And so we learned a lot of lessons as we put together our program. We learned that team is spelled with a capital TEAM, and it's not, the proceduralist is an important part of the process, but it's an entire team effort that makes it work. And I'd like to kind of go through the components of the team that we've discovered that are essential. It starts with our preoperative screening. Our ultrasonographers really are asked to do a different anatomic study than what they are normally accustomed to do in terms of evaluating patients both pre and post AV fistula creation. This is certainly not a standard vein map. Our ultrasonographers have to become familiar with identifying the perforator, measuring the size of the perforator, which is really the crucial part, and then determining whether the ulnar or radial vein is going to have reasonable proximity to the target artery. In addition, we discovered early on that bringing our ultrasound team into the operating room and upgrading our ultrasound experience in the operating room became essential for creating fistulas with a high degree of frequency. And so we upgraded our techniques by bringing a enhanced ultrasound console into the operating room, having the ultrasound techs present in the operating room, using ultrasound to clarify that our wires were intraluminal rather than doing contrast injections. And this has greatly enhanced our ability to successfully create a fistula. In terms of the follow-up, again, ultrasound is extremely important. With WavelinQ, we've determined now that the ultrasonographers have to follow the perforator, especially because sometimes the perforator matures well and sometimes it does not mature well. We've discovered that post-creation, even though we think we coiled what we would believe the most probable competitive veins, that there are veins that sometimes become a real sink and steal blood from the WavelinQ fistula, and the target vein never really achieves a flow that's successful. We've also learned that our dialysis center is our partner, and maybe our most important partner, because the cannulation of the WavelinQ AV fistula is different than the cannulation of a graft or of a surgical fistula. These are all moderate flow fistulas. These are not high flow fistulas. Our what we would describe as a successful fistula will have a flow of anywhere from 550 up to probably about 800 milliliters a minute tops. We certainly don't see any of the WavelinQ fistulas with flows greater than 900 to 1,000 milliliters a minute. So what the dialysis technician encounters from a palpable point of view is completely different than a prosthetic graft or a high flow fistula. In addition, in our area, we have technicians cannulating, and although we would love to have ultrasound-based cannulation, we don't have that. And so it's been really important for us to support our dialysis centers, really from the first cannulation right through successful 2-needle cannulation and then ultimately removal of their tunnel catheter. So we started from scratch. We're in a community hospital. We took one of our standard operating rooms. We upgraded our imaging system to a oversized flat panel, but we still do them under C-arm. Our technical support is our endovascular operating room staff. Thankfully, they became very excited about this technique, so everybody bought into it and wanted to be part of the team. We launched on a real effort in terms of outreach into our nephrology and dialysis access center community. We do a periodic dinner, usually about 3 times a year, where we invite people out. I do a demonstration and present data, and then the most important thing is we open it up for questions, because this is all new and different. And one of the pushbacks that occurs with any new technique is unfamiliarity and suspicion. And I found that the best way to overcome that is in a face-to-face manner. We now have emissaries that have started a lunch and bond program. My PA, my nurse, and one of my medical assistants, to get away from me, will go to Panera's or some other place and get lunch and go out to a dialysis center and spend an hour or so and not only talk about what WavelinQ is about, but more importantly, listen to the feedback of the individuals at the dialysis center and learn what's important to them and where their pressure points are and what we can do to make their lives easier.
George, that was great. I really, I'm looking at the last part of the slide here, seeing that you've got your own candidate rating system here. Would you mind going through that system to let us know what you're doing to screen and set up these patients?
Well, absolutely, Todd. We screen everyone who is referred for hemodialysis to determine whether they're a WavelinQ candidate or not. We've developed an A, B, and C system for grading individuals. For us, a grade A means all the anatomy is outstanding, and I'll go through that in a moment. A grade C is an individual that has a problem that we can't fix, and the message from the ultrasonographers to me is, don't take that patient to the operating room for a WavelinQ. And a WavelinQ B has anatomy that will allow the WavelinQ to be created, but the ultrasonographer has some concerns about the ultimate target vein, and that the target vein may require a secondary procedure. And that helps me in terms of counseling the patient as to whether they're going to have 1 procedure, 2 procedures, or multiple procedures. So let's go back to the WavelinQ A, which is the happy ultrasound. So that patient is going to have a perforator that's 2 millimeters or greater. It's going to connect to either the ulnar or the radial vein, most of the time to the ulnar vein. That ulnar vein will be of reasonable diameter, usually about 3 millimeters. There will be proximity between the ulnar vein and the ulnar artery, less than 1 millimeter. And then that perforator is going to drain into either the basilic vein, the cephalic vein, or both veins, and each of them will be unencumbered by fibrotic lesions from either IV starts, blood draws, PICC lines, or other forms of venous trauma. The anatomy of the arterial side has not been a problem in determining whether the patient is a candidate or not. So the WavelinQ, the grading system for the WavelinQ primarily relates to the venous anatomy. And if the venous anatomy is favorable, then we're going to go ahead and do a WavelinQ.
George, that is a great, I love your program, I love your protocol, and you did a great job explaining how you're looking at that.
Now, the other thing that I failed to mention is that on our screen here, you have our what we call our screening ultrasound map. What we do once we've decided to go to surgery is that we have a cleaned up, coned down operative map, which I take with me to the operating room when we hang up on the wall. And that clearly defines exactly what we're going to do, whether our venous approach is going to be proximal from the upper arm, our distal antegrade, whether the arterial anatomy is standard or whether it's a high bifurcation, where we believe that the creation zone should be, so that the efficiency and the focus of the team is not on what are we going to do, but it's just moving through the steps of creating the WavelinQ AV fistula.
That's excellent. I couldn't agree with you more. It's all about screening, getting the right patient, and creating that fistula in the proper artery and vein combination to get a functioning fistula that does mature.
So Todd, in last December, we looked at our interim experience that went for about 8 months. At that point, we had gone to the operating room with 76 patients with the intent to create an EndoAVF. I created 56, which means there were 20 occasions in which I was unable to create an EndoAVF. And although that may be disappointing to those who are listening, it was important because we learned lessons, and like everything in surgery, when we had a problem, we thought about what caused the problem, and then we came to a solution. And so when I look back at my failures, the most common problem I had was problems with gaining venous access. We've already talked about how we've solved that problem. That is no longer an issue. We had some circumstances in which we had wires that were crossed, and we were only going from the upper arm, and we were not going from the wrist as a backup maneuver. And those circumstances we didn't create. Now, on the bright side, we created 56 fistulas, and then we followed them to see what was going to be the natural history. We found that we did have to do some secondary procedures. In my geographic area, if the basilic vein is going to be a target vein, that basilic vein has got to be transposed or elevated. We don't cannulate by ultrasound in our area. We don't have registered nurses that cannulate. And the basilic vein has got to be lifted up and stuck right on the top of the arm under the dermis, and it's got to be an easy stick for our technicians to stick. We transposed a couple of cephalic veins. We did have problems with issues of veins popping up that were competing with our target vein for flow, and we went back and coiled them in an effort to try to redirect flow. We've actually had to do a couple of venoplasties. I think that the one thing that has sustained me more than anything during all of these hiccups in the learning curve are the patients who ultimately achieve 2-needle dialysis with an EndoAVF, and those patients are unbelievably excited because they, as you know, a dialysis center is a small social group. All the patients can see everybody else's arm, and the arm of a patient with an EndoAVF doesn't look that much different than a normal arm.
I feel that as time moves forward here, this is becoming more patient-driven. Patients are sitting in a chair next to somebody who's got an EndoAVF, and they're like, hey, how come yours doesn't look like mine? And I think one of the biggest, patients are becoming more savvy, and I'll have patients come to my office questioning EndoAVF, wanting to know more about it, wondering if they're a candidate for it. So it is really interesting that just like other areas in surgical and procedural-based medicine, patients are driving the ship, so to speak. Patients are more savvy, and they are coming to us knowing about this technology. feel like WavelinQ lends itself into that armamentarium of things you can offer a patient. This is really the first time in the fistula creation world where patients had an option. They want an option, they're happy to have an option, and I think as physicians, we're happy to be able to provide another option.
So Todd, about the issue of aneurysms or steel, well, these are all moderate flow fistulas, and so haven't had anything that looked like an aneurysm. And to date, we have not had any patients with symptomatic steel. Well, everybody's going to learn their own lessons, and that's kind of a personal experience. But now that I'm over 100 of these down the road, the things that I have come to appreciate is that there's a learning curve. The anatomy that we deal with is not standardized, especially on the venous side, and the technical nuances of doing the procedure are different from case to case. And so I happen to like that because it is intellectually and technically challenging, but there is a learning curve, and for those who are watching this, one should not be discouraged by the learning curve. I would view it as an opportunity for personal growth rather than a burden. I think that in a comprehensive dialysis access program, which is what we hope that everybody will have, that the EndoAVF is a great tool. It's not going to be perfect for everybody, but it is a great tool, and especially as I've pointed out previously, for the CKD4 patient who has adequate metrics to have an AV fistula placed prior to the initiation of dialysis, it is a great option, and it's one that patients are receptive to since it's minimally invasive. I think that you have to be aware, depending on your locale, that secondary interventions may be required. Lastly, well, the one thing that I learned is that when I did not create create a fistula in the operating room, I did not burn any of my surgical bridges. A failed EndoAVF, in my experience, did not result in any lost territory from an anatomic point of view.
This is great. I think these are all points, and to your initial point, where we're all gonna stumble a little bit. We're all gonna figure it out and learn and have some life learning lessons throughout this procedure. There's this old adage in surgery that there's not enough time to make all the mistakes on your own, so you've got to learn from everybody else. I enjoy hearing you talk about this because these are all little tidbits of information that all of us as proceduralists, as surgeons, as interventionalists, we can kind of put together. And really what this is we've got to learn from each other on this.
Boy, I couldn't agree with you more.
George, it was great hearing about the Bethesda experience. I like to just have a little back and forth talking about EndoAVF. We've heard about why you've adopted it. We both agree that this offers another option for patients, for some patients, and that this has become patient-driven. What about your referring doctors? What about the nephrologists? What have you found that's important to them from the EndoAVF standpoint? Have they enjoyed the success? Have they appreciated the results that you're getting?
I think they appreciate the fact that there is a minimally invasive option, that they can tell the patient that your surgeon is going to discuss this with you. Now, on the flip side, these are moderate flow fistulas, and the cannulation requires a new level of effort and focus in the dialysis center. And if we are not careful in terms of backing up the dialysis center with education and physical presence, the dialysis center can have difficulties with cannulations, extravasations, which they find frustrating, and that can feed back to the nephrologist, and we can get pushback. But in general, I think that the nephrologists understand that catheter-based dialysis has a higher mortality. They understand that CMS is looking at their units to look at their catheter rates. They understand that if there is an access program that can offer patients options in terms of getting rid of their catheters, that they're interested in embracing a program that will meet those needs that they see on a day-to-day basis in their units.
Why should this be important to vascular surgeons? particularly surgeons that may have been in practice for decades who have a well-established access practice. Why do they need to adopt EndoAVF?
In every aspect of the practice of medicine, change comes, and it's important to look at change with a critical eye to make sure it's not just change for change's sake, but is it change that improves the patient care? And if it's change that improves patient care, then it's either you lead, you follow, or you get out of the way. I would say from our point of view in our program, since we've embraced WavelinQ, our volume of all forms of dialysis access has from a very high base, it's doubled.
That's fantastic. And to the last point on the slide, you had mentioned this, and I can certainly attest to this as well. If and when it's not successful, it doesn't burn bridges for future surgical AV fistula creation. So we're not burning a bridge, which is nice.
Absolutely correct.
Fistula creation surgery has been stagnant for decades, and now finally there's another option with WavelinQ EndoAVF. Where do you think the patient's role comes into this? Again, we touched on this before, but let's just bring it home to why is this important for patients?
Over my career, I have been astonished at the amount of direct dissemination of medical information to patients that occurs. Truthfully, patients are more empowered to become part of the decision-making process, which I think is wonderful.
I think that's very well put. I agree with you on all of those. I would just say that anecdotally, that first bullet point there, when I was first doing this procedure, I guess I underappreciated how important the body image was. Patients are really dissatisfied with those large runaway fistulas with these ropey snake-like veins. And I'm amazed at the number of patients that are coming in requesting to not have that. They know they need dialysis. They're referred to me. They're seeing a vascular surgeon. All they know is they don't want that. They've seen that. They've Googled images. They may know somebody who's on dialysis and sees their fistula. And I think that's where EndoAVF lends itself because of its moderate flow. You don't have these runaway fistulas with big aneurysmal veins. And when it comes to body image, I truly underappreciated how important that was to these patients. Okay, now we will move on to our discussion with how will EndoAVF fit into managing dialysis patients during and into recovery from a COVID pandemic. And we've got our New York City experience with us here in the, so-called epicenter, unfortunately, of it, where we were redeployed to working the reworking the COVID ICUs and COVID wards, to a very different experience down in South Florida. And George, I see you're wearing a different shirt. You've had a wardrobe change here.
Well, Todd, I have. When we talked earlier today, I thought it was really ironic that here you were deployed into the worst concentration of COVID-19, and you did fine. And here I was down in South Florida, and I acquired COVID-19 from one of my dialysis patients. And so we learned some lessons in this, how contagious the virus is. I was out of work for 3.5 weeks, lost 20 pounds, fortunately never had any respiratory symptoms, never had to go on oxygen, and did not take any medications, and was able to manage the whole thing at home. The reason for the wardrobe change is that our blood bank, One Blood, if you donate convalescent plasma, the thank you is you get a convalescent plasma t-shirt. The one thing that we did learn is that it's highly contagious, and our dialysis patients are in a relatively confined environment in the dialysis center, and the only dialysis procedures that COVID positive patients are getting are catheters, or catheter exchanges. We are not doing arm access procedures on COVID positive people at this time.
I think that's a very reasonable protocol. We were definitely just putting catheters in patients, COVID positive patients that needed access. And just now, as we're in this convalescent period, we are now signing these patients back up for access. Certainly, though, patients who are COVID negative are worried about contracting the disease. Do you typically create your fistulas in the main OR, or is it in an ASC? Is it an outpatient type of setting? Patients are certainly worried about contracting it, and there's a fear for coming into the hospitals at this point in time. Do you think EndoAVF lends itself well in this kind of intra or post-COVID pandemic period?
Oh, how relevant a question. So during the period of time that I was out, we accumulated 93 patients on a waiting list. And once I was back and the hospital allowed us to start doing elective surgery, we started calling people up. I mean, you know the data that from CMS that every patient on hemodialysis is going to get somewhere around 2 procedures per year to maintain their access. When their access fails, they now have a lethal situation. And so there's going to be ongoing need for access procedures, either creations, revisions, and whatnot. And we just have to adapt ourselves to a system that provides the patients with confidence that they can get their procedures done in a safe manner.
I think that's all you can do, and I think we're all trying to do our best. Any final words of advice to a physician, whether it be interventional nephrology, radiology, or vascular surgery, who's interested in getting into WavelinQ or EndoAVF? Any guidance or opinions or advice that you could offer?
Boy, oh boy, do I have guidance and opinions. Number one, don't look upon a procedure, build a program. Value every person in your team as much as you value yourself. And then, be committed for the long term, because the dialysis access is not an episodic event. It's a commitment to a patient for their lifetime.
I echo everything that you've said. I also agree that patients, or I should say physicians that have just dabbled in it, I think ultimately it's very difficult for them to be successful. I think if you're going to commit to this, you've got to screen all patients for EndoAVF. You really can't cherry pick who you're going to screen. You should screen everyone. If you're going to cherry pick, take the best of the anatomy. One thing that I underappreciated early on that I've come to really appreciate a lot more, it really comes down to the size of the vein where you're creating it, whether it's the ulnar vein or radial vein.
Absolutely. I would agree completely.
That's right. And I would just say for the listeners out there, for Dr. Mueller, myself, I'm certainly would happy to be available. I do make myself available to all of the attendees that come to the EndoAVF course. My cell phone's always on, email, cell, text. I'm always happy to chat about this. For a lot of us, not only this is a hobby and a love and a calling as much as it is our profession and our job, so to speak. So this is something that we all love to do, and I just hope that everyone else can embrace it as well.
Absolutely. Couldn't echo that. Agree completely.